My guests tonight are Mikhail Kogan. He's the medical director at the George Washington Center for Integrative Medicine and founder and executive director of AIM Health Institute. And Joan Liebmann-Smith, who's a medical sociologist and medical writer. They are the co-authors of this book, Medical Marijuana, Dr. Kogan's Evidence-Based Guide to the Health Benefits of Cannabis and CBD, that was published by Penguin Random House. So I want to thank you for both being here. Dr. Misha is a little under the weather. He'll give you the details. So why don't you both, start talking for a little bit and tell us about, your backgrounds and how you got to actually write a book together.
You first.
Joan, I think by the seniority, you should go first.
Oh, no.
I also want to mention that we have another participant over here. His name, he has about 5 different names, but most commonly is Noodles with Z at the end. So he's our COVID dog, and he's part of my healing. So I'm actually acutely having COVID, and usually I get over things very quickly, and I thought that I'll get over it within a day or 2, but it's now almost a week and I'm still having some symptoms. So hopefully it's not going to be long COVID, but him on my lap helps. I've been in practice of integrative medicine for probably closer to 15 years independently after residency. And when DC legalized medical cannabis in 2010, around about the same time, Andrew Weil asked me to join American Board of Integrative Medicine as a founding board member. And at that board, I met, well, back then I didn't know him, but I met Donald Abrams, who's probably a father or probably grandfather of all things research cannabis. He's retired recently. He was the first person who got the NIDA, National Drug Enforcement Agency grant to study this medical applications of cannabis. Back then it was for HIV/AIDS in the early 90s. And so he kind of, over the years, talked me into getting involved. And in 2012-13, I started recommending. And by the time Joan and I met, which I think, Joan, was it 18, 17? I can't remember.
I can't remember.
Something like that. And Susan Orleans is our matchmaker. Yeah, well, since through the whole process, Joan became my New York Jewish mother. I'm not sure it's really a match process. It's I don't know what that is. Adoption process of some sort. Anyway, so we are actually originally we're going to write a book about geriatrics, since that's what I do. I mean, I'm a geriatrician, and the idea was to write a book on. Well, we had 2 possible projects, and so one was just geriatrics books, the other one was cannabis in geriatrics. But the Penguin people said, forget it. We need a cannabis for everybody. We said, okay. So that's in very quick. Joan, why don't you go and say a little bit about on your end, and then we'll come back to me and I'll talk.
Well, I think the interesting thing is, well, Susan got us together, our friend, and we hit it off immediately. And even though Misha's a young geriatrician and I'm an old sociologist, we figured we'd make a good pair. And it was very interesting working with a physician. I mean, I've worked with physicians. I've done a lot of editing, co-writing with physicians, but never a book like this. And we learned a lot from each other, and we fought a lot and we laughed a lot. I think we laughed more than we fought.
I don't know about that. I'm still like, every time I look at the title, I'm like, oh my God.
I know. So, okay, I guess
we'll talk about it.
Yeah, we'll talk. You don't want to address the elephant?
No, you can talk about that now. If you want.
Okay, we had a big issue over the word marijuana. Misha, you say why you had a problem with the word marijuana.
Yeah, because it has no medical, botanical, or any kind of clinical meaning. It's a pejorative word that was coined by Hesslinger in whenever, this is a long time ago. And the whole point was they needed the scapegoat to get funding for the agency. They had to come up with some bullshit, total lie from. So they made up the word, made up the story, made up everything. There was a zero truth in everything they were talking about.
Right.
So then the whole, myth was created. And so the word was really just so that they don't use word cannabis, right? Because the cannabis was highly respectful. It was standard, sold in every pharmacy in the United States. It was part of pharmacopoeia. It was actually one of the most commonly prescribed drug by every physician. AMA, American Medical Association, back then heavily was invested in the cannabis, heavily supporting. The only organization when the commission on the Hill, basically when the White House was prohibiting it, the only organization that said, no, we can't get rid of it. It's crazy. We need cannabis was AMA in the 30s, right? And so he came up with a word and it is just stuck and it took off. And now we have to deal with this. So now, Joan, you tell us why. I mean,
Well,
it's actually
he didn't come
well,
up.
I presented one side, right? Because I
Okay,
didn't
didn't
want
come
it
up
since
with
we just want the word cannabis. But of course,
Okay, so I want to focus on what the book's about.
You don't want to
good.
hear it, right?
You know,
Yes, and so we for the audience, if you have questions, please put them in the Q&A box, which is on the bottom of your screen. Don't put them in the chat box because that's for me and my co-chair, Joe Bonner, who's running the camera behind the scenes and producing the show, and for Misha and Joan, to chat if we have questions. So put them in the Q&A box and we will get to them. I'm very pleased that we have a good turnout and a lot of interesting questions. So I went to a Association of Healthcare Journalists meeting a month after Colorado made recreational marijuana legal, and medical marijuana was already legal. And so I went with a friend to another fellow journalist to a store, and they scan your license because you can only visit 3 stores a day, make 3 transactions a day. And then they said, how do you want to feel? And I said, what do you mean? He said, well, do you want to feel mellow? I said, do you want to feel jacked up? And Misha, you talk about there's a lot of misinformation out there, and I'm thinking, what does this 18-year-old kid know about which product is going to really do that, and how do they know? Because at the meeting, when the governor and his health secretary and there's a pharmacist there, I said, there's a reason they give 2 aspirin. There's a reason they give 2 weeks of certain antibiotics. And he said, we don't know about, marijuana affects people very differently, especially when they ingest it sometimes. Maureen Dowd had a full psychotic episode ingesting it. And, and I've seen people, when I was in college, I saw people have marijuana and feel really mellowed, and other people get very paranoid. So it's very hard to, it's not as, so I kind of looked at this guy and saying, is there a guarantee? And there isn't a guarantee. So, so the first thing I want to address is that you were just in Israel, and so you can talk about, you were at the 6th International Medical Cannabis Conference in Tel Aviv. But in the United States, I've actually seen a seizure stopped by marijuana, an epileptic seizure. But in the United States Misha, the United States is still hampered in doing research in marijuana. It's a schedule. Yeah,
that's probably the sort of the crux of the issue here. Let me give you as an example. So Israel invests millions of dollars into this topic, and they have extremely serious large labs there's like 2 labs that they were presenting, both with a staff of 30, 40 people. And the amount of experiments and research that they do is just unbelievable. And, they have a federal funding, and then they have industry funding, all kinds of funding. And so the part of the problem here is something like this only beginning to show up in America. So we are still decades behind, even though if you look at the products, we have hundreds of times more products in the United States. So we have a market flooded with different stuff. None of this is researched, zero. Not a single product that's currently in the US dispensaries has went through any formal research testing, none. Versus in Israel, everything is tested, everything is researched. Every product on the shelf went through a standardization, formal testing in the labs, and often actual clinical studies that were using the products that they can buy, the patients can buy. So, you know, you have a disconnect, which is good actually in a way that our patients in America have more choice, but it's not necessarily better because you don't know what's working, what's not working. Exactly what David's saying, you know, patient shows up and 18-year-old says, oh, just get this because you'll feel mellow. What the hell is that supposed to mean, right? And the problem most of the time is the fact that, you know, patient shows up and the doctor can't even say anything. Like I would tell patients what to get from dispensary, and then in dispensary, I often hear the patient say, oh, no, your doctor doesn't know anything. Like literally, or they would say, nah, you don't need this. It's sort of like what I tell to the patient when they tell you that, it means that they need to sell some other stuff, and what you actually need, they don't need to sell because they have a low stock. And, you know, it's a poorly regulated business still. It's even
pharmacists wouldn't tell you that.
Right. So, but, you know, it is changing though. And the good news is that more and more states requiring each dispensary to have a clinical staff on stuff. Like there's Connecticut, for example, where you must have a pharmacist on staff in every dispensary. Now that increases prices, but eventually I think that still is the right thing to do. You have the clinical director. Maryland, so I'm in DC, Virginia, and Maryland, licensed in all 3 states. Maryland just approved requiring to have a clinician in each site, in each dispensary. DC is following closely. They're right now just created the process to do that. Now I select the dispensaries, which I tell patients to, you know, which ones are better, where there is already a clinician on staff. So that's just sort of one of the things that I'm quite big on. But I think you also had another point in that line of discussion as to, you know, the fact that we're going to have problems with research and problems with just the general accessibility of knowledge and general acceptability by the scientific community and by medical community, just because it's still Schedule 1. And my prediction is we have less than 5 years before it's going to get, and I think it's going to get descheduled. So for those who are listening who don't understand what we're talking about, so the DEA has a different scheduling system. If the drug is deemed to be safe, not addictive, and has therapeutic potential, it will have no schedule at all. So aspirin, you brought up aspirin, right? So aspirin is not scheduled substance, but codeine is. So the heroin, for example, is Schedule 1 for a good reason, right? So the heroin has about 90% dependence and addiction potential, very high mortality rate, and you can use other drugs for anything that it can do. So cannabis has less than 10% addiction, 0 mortality. Not a single person ever died from cannabis in the entire history of humankind. And yet it's also Schedule 1. So total disconnect. Makes no sense whatsoever. You know, alcohol is not scheduled substance. It's about 100 times more deadly and toxic than cannabis, and it's about twice as more addictive.
Alcohol stores never closed during the pandemic because it was considered an essential service.
Well, neither is the cannabis.
Right.
In every state, it's remained essential service. Sales went up at least 2-fold. Same with alcohol, by the way. Okay. And you know, so the cannabis industry prospered.
I think cocaine is also Schedule 2, not even Schedule 1.
Correct. Cocaine is Schedule 2 for only one reason. It's used as an anesthetic in some procedures, like I think sometimes it's used as a throat numbing agent in some endoscopies and other things.
It's also used for the nose and eye. I had to have some.
So, yeah, so descheduling means totally removing the schedule. So going from Schedule 1 in case of cannabis to 0. And then rescheduling, which would also be good if it happens. It would be to go from 1 to anything less, more than 1, like 2, etc. That will open the opportunities for federal funding. The problem with Schedule 1, you cannot obtain any federal funding. There's no legal mechanism to obtain federal funding if there's a substance, if it's a Schedule 1 substance. You can get authorization for the trials, and you can get federal funding for studying of side effects, but you cannot study efficacy because there is no efficacy according to the DEA. Right?
So how is it legal for states to have dispensaries when marijuana is not legal federally?
So the way to get around this, they say, look, we will remove doctors from prescribing. So there is no doctor anywhere in the US who can prescribe cannabis. It's not legal, you can't prescribe it. So the states that have legalized medical cannabis, what they say is you have to write recommendation and then state takes over. So and this is the whole problem, this is the whole craziness of the dispensaries and all this 18-year-old butt tenders, we call them, right?
Right.
Butt tenders. You got that?
Butt tenders.
You guys, everybody got that joke? Very good. Anyway, so that's how they get around and making all the recommendations, because physicians can't, because the states legally separate patients from dispensaries just for that particular reason, because it's Schedule 1. The moment it would not be Schedule 1, then I can prescribe it. Then I can actually write a script and then all bets are off, because then I say, look, you go get this particular strain in this particular dispensary. This is the dose. But legally, I cannot do that. I can't tell patients what to get and where to go because I'm prohibited by a state. This is how they separate. That's how they deal with the DEA problem. Now, federally, DEA can say, screw all of this. We're going to arrest every doctor prescribing because they actually have a right. And those of you who are old enough and fascinated enough with this whole legal conundrum may have seen the cases like this back in California in 20, 30 years ago when the cannabis was approved first there for medical use, and then feds didn't like it, and there were multiple arrests of physicians and dispensaries shutting down and all kinds of raids and all kinds of old stories. If you get lucky at some point, we should bring Donald. He'll tell you the stories. Your hair will stand on your head, and that'll fall off, because it's just the sum of the stories that back then, predating my time and Joan's time, they were insane.
I want to mention from your book, so pot in the past. Herodotus, the ancient Greek historian, described pot smoking in his book, The Histories, which is written in the 5th century BCE, 2,500 years ago. And recently, archaeological discovered physical evidence in Western China that cannabis was also smoked 2,500 years ago as part of religious rituals and for healing purposes. So it's been around a very long time. There's a lot.
It's the oldest known medicine to the world. Okay. We don't know of any medicine that is older than that.
Okay, so I do want to ask you, because you're also talking on the same page about smoking and vaping, and you talk about how that the epidemic referred to as e-cigarette or e-valley, e-cigarette or vaping product use associated lung injury. Does that, so I know that people were very excited when e-cigarettes first came out. And now there's a question about it. So is that a problem with marijuana smoking?
No, it's really not a problem of anything, actually. It's just a bootlegged stuff. They're using the chemicals that they use to cut the solution were the problem, not the tobacco or the cannabis. So this is just another highlight of the fact that until we standardize this field, until we legalize it and make it appropriately overseen, and just like any other medical field, right, we're going to have these problems. So this is on federal government. The fact that we had hundreds of young kids, basically, 20s mostly, die is on federal government. It was their responsibility to say, look, we're going to regulate it appropriately. They didn't give a shit. They just kind of, And they still don't. They still let it all just kind of, it's free for everybody. Right now, you can still go and get bootlegged stuff anywhere in the country. And EVALI disappeared because any reasonable producer, after all this happened, said, wait a second, we got to relook at our manufacturing process. They even bootlegged stuff because, of course, who wants, it's bad for business if your customer die, no? Last I checked. So that at least got solved because everybody's now aware of it. But there's going to be other problems until we regulate it. And in order for this to regulate, there has to be a national standard and a federal process requiring descheduling or rescheduling. Going back to same issue.
So I want to address, kind of a little elephant in the room, because you have a forward by Andrew Weil, and people like Andrew Weil and Dr. Oz have been criticized for talking out of their specialties. Especially Dr. Oz lately, who's become very right-wing and denouncing all kinds of things. And so so your book,
Well, first of all, let us make sure that we're all on the same page, right? So Andrew Weil is highly respectable academician, is a
Right.
professor of medicine at the University of Arizona, is donated millions of dollars to the University of Arizona. I was trained, I did my rotation. Dr. Oz is an entrepreneur. I'm an academician. I have nothing to do with this. I don't want to go to places I don't know anything about. So I don't want to discuss this, why he's right wing or whatnot. Don't care. So Andrew Weil, everybody's critiqued, and integrative medicine, what we call, which is a combination of East and West, the best way I can say in 30 seconds. It's still on the verge of being fully accepted, but we have our own board. We recognized by every state, we recognized by every university in the country. Every major university has integrative medicine center. Students required to learn this. There is a standard accreditation. They can't pass accreditation if they don't learn. This is why my salary get paid, so that I can teach students what I do. So that's just to be clear, right? And then within the scope of integrative medicine, all kinds of things fall in. And that's, maybe we can a little bit talk about that. But the point there is cannabis falls within integrative medicine very nicely. And going back to the book, I don't claim that my main proficiency is cannabis, because it's just one of my tools out of many in my toolbox of integrative medicine. In fact, in some ways, I probably know more about some other supplements and vitamins and herbs than I know of cannabis. It's just cannabis happens to be a very complex plant.
Before we go to questions, I want to give Joan some equal time here, and she can talk about the historical and sociological aspects of marijuana and what you brought to the book, which I did read. She was actually very surprised that I read the book. I said, I read all the books, even Carl's or Zimmer's, which are 600 pages. So I read them. So anyway, so your perspective that you brought to the book.
Well, I very much believe that in order to understand the present, you have to look at the past, and history informs us as to what's going on. And I think my favorite chapter was, doing the history chapter, where, as you brought out, in ancient China, cannabis was used for a myriad of conditions. I mean, everything, constipation, women's problems, and then throughout the Middle Ages, it was used. It was a lot of things with ear. I was surprised. Earwigs and earworms. It was put in ears a lot, but it was around, and it was the only place. Misha knows more about this than I do, but the only place it seems to have been banned, I think it was the 12th century in Jewish and Muslim countries, it became banned. It didn't become banned in the US until 1937. So it's very weird that other countries, they might have had prohibitions about this and that, but cannabis was used. And the way we got to where we are now, the long and winding road, as I call it, is cannabis. It was actually, the term marijuana came from Mary Jane, and it was sort of a term used by Mexicans. And Mexicans were immigrants, and they were thought of the way many people think of them today. They were smoking marijuana to relax. It got spread around the country, not just by immigrants, but by jazz players and singers, by white people, by artists. And this outraged a lot of people. I think one of the big problems was that Blacks use marijuana, and they started this thing that Blacks were raping women and seducing white women. And the government got outraged. They believed this. And then the Reefer Madness mentality set in. I think a lot of people are probably aware of that movie. So basically it became stigmatized, and pot smoking was associated with bad people, with hippies, hipsters, they called them. And then in the 1970s, I think it was 42% of white college students were smoking pot. And that did Nixon in. I mean, he just exploded. And actually, I have this amazing quote that I could dig it up here. He said, so Nixon, this is in government records. He said, "I want a goddamn strong statement on marijuana. I mean, one on marijuana that just tears the ass out of them. Every one of those bastards that are out there for legalizing marijuana is Jewish. What the Christ is the matter with the Jews, Bob?" He was talking to Bob Halderman. "What is the matter with them? I suppose it's because most of them are psychiatrists. By God, we are going to hit the marijuana thing, and I want to hit it right in the square puss." That's a quote in our records. So
as far as I know, Willie Nelson is not Jewish. So,
he's not a psychiatrist.
I want to talk a little bit about the book. So, because we're not going to have time to really discuss all the things, but you talk about marijuana for aches and pains. You talk about marijuana for, or cannabis, if that's better, sleep and mood. You talk about it for cancer, GI disorders, neurological conditions. I mean, I think most people know that, it's used for pain, and also for a lot of people, elderly people first use it when they have chemotherapy. It seems to help in glaucoma. So those are the two most uses. But let me start getting to people's questions, because there are a lot, and I'm grateful that people ask questions, and then we can circle back after that. So here's the question: what is the best way to consume cannabis? Does smoking cannabis impact the lungs in the same way as others smoke? And what are the long-term effects on the brain?
So I think each of those questions I could probably answer in weeks' time, like literally, there's that much data. So no, cannabis does not affect the lung the same way as tobacco. There is zero risk of lung cancer with the smoking pure cannabis. We don't know about the vaping, by the way, because it hasn't been around long enough. So all the prior studies have been either done with vaping of the flower or with the smoking of the plant. So vaping concentrates to this oil cartridges, we don't know. But no, it's not the same effect, that's for sure. The issue, though, that it's still the same effect in terms of bronchitis, chronic smoke, and kind of this, because you hot substance being inhaled, you suppress your ciliary tract, so you don't expectorate very well. Eventually, you're going to develop chronic cough and bronchitis, and maybe slightly increased risk of chronic obstructive pulmonary disease, COPD or emphysema. So for that reason, I think most of us would try to tell the patients not to smoke or inhale, especially given that in US we have so many choices of sublingual and topical and rectal and edibles and you name it. Next coming eye drops, working on that, by the way. That's probably gonna get approved sooner than you think. So all kind of routes of administration that can be given, so why to smoke? So that's the first part of that question. I think the other part was in terms of the long-term brain impact, is that?
Yes.
So that's a harder question to answer. What we know from animal studies, particularly, that the pure THC, so one of the main cannabinoids or main active ingredients in plant cannabis called THC and tetrahydrocannabinol, and there are different numbers before 9, for example, or 8, etc. So 9 is the most common one that's used recreationally and also medicinally. So we do know that if it's unopposed with no CBD or other molecules, there seems to be a chronic negative brain impact, especially on developing brain in animals and probably in humans too. What's interesting, what's bad for young appears to be very good for old. So you give high dose THC to old mice and you basically completely prevent Alzheimer's disease, 100%. So far in the lab, in the studies, which who knows if that applies to humans, but in the animal models, the cannabis appears to be one of the most profound anti-dementogen that we have. There is a basically clear understanding why that's happening, and that has to do with the way our system, our endogenous cannabis, because we make our own cannabis our whole life. Highest amount is made when you're around 12 to 14, and then the game's over. After that, it's just all downhill. But by the time we reach about age of 60, 65, we have a fraction of internal cannabis left compared to the youth. And the thinking is that because of that, that some of this neuroregenerative stimulus that cannabis can create or does create in the brain disappears. So if you reconstitute it with exogenous cannabinoids, which basically work similar to endogenous or internally made, then you can prevent Alzheimer's. Whether you can treat it or not, it's there's a question in the chat I see about specifically cannabis for dementia. So that's where Israel actually has a lot of data. That's what was a lot discussed at this conference. We're still very early in phases of discovery there. I would say, I wish I can report that in clinic I see some miracles. I don't. I think the part of it is dementia research is very difficult. It takes takes many years to show anything because the disease is slow. So whether or not we ever going to see cannabis being actual part of the cure, I personally believe it's going to be the most profound treatment for Alzheimer's we ever will have. It's my belief because I see where the science is going. When will we get there? I hope in my lifetime, but I think we will. But in terms of...
We also talk in the book about how you've used it for agitated patients who have
Alzheimer's.
So
right. So, but that's right. So that's not necessarily outcome. That's not necessarily on dementia. This is a side effects of or process symptoms related to dementia. So it's actually a very good treatment for agitation or what we call a neurobehavioral changes in Alzheimer's disease. I would consider that a standard of care at the moment because the current standard of care, which is a medication such as tranquilizers, they're all increased risk of mortality. So they may make the patient calm, but they also will kill the patient sooner. And that's universal. So all of those drugs increase mortality. They're all on what's called the Beers list criteria. So they should not be prescribed unless there's no other way of handling the situation. So if there is a cannabis, that should be first line. Now, of course, not every state patients can obtain it legally. And then there's also problems if the person is in a nursing home. That creates a whole level of complexity as to within the institution may decide not to allow dispensation or prescription. So
here's a great question, and something we didn't touch on, because you also, your book says the health benefits of cannabis and CBD. And someone asked about, for arthritis pain in the knees and foot, is it better to use a TCH CBD cream, a CBD cream, or a THC oil? So first, why don't you explain what a TCH CBD cream is?
Okay, so the THC and CBD. So let's just first, so THC stands for tetrahydrocannabinol and CBD stands for cannabidiol CBD. Both molecules can be used for arthritis. There's no question about that. CBD has no analgesic properties as far as we know, but it's a pretty potent neuroprotective molecule as well as anti-inflammatory. So arthritis, by definition, is an inflammatory condition. So we go over in the book, we go very in a great detail of even particularities of ratios. So for arthritis, I love to use 1:1 THC to CBD ratio, THC for pain, CBD for inflammatory process. And topically, if it works amazing, that's great because the side effects are much lower. Topical also has another advantage. You can put it frequently and not worrying about accumulation or not worrying about if there is a little bit of a psychoactivity with sublingual or oral. You're not going to get that with topical. The problem is topical often doesn't work. So topical efficacy is much less predictable compared to the oral. Has to do with absorption, has to do with what is actually hurting. If what's hurting is inside the joint, it's not going to penetrate, because when cannabis applied, the depth of penetration from topical it mostly works as superficial treatment. But if you have muscles around the knee that's really hurting, or there's in spasm because you're overcompensating and bearing the weight off because joint is disrupted, then it actually could be the most effective treatment. So
the THC is that the substance that gets you high?
Right. So just one word of caution. We don't use word psychoactive anymore because every cannabinoid is psychoactive. I have people taking CBD say that they feel slightly off. So that's a psychoactivity. We use word now psychotoxic. So that's an actual word describing effects of THC. So the high, the recreational high is the word for that scientifically, psychotoxicity.
So there are a lot of drugstores in New York City near me that sell CBD oil. They do not sell medical marijuana.
Oh, don't get us started, because this whole thing with Delta 8 THC now, which can be bought in every store, in every hemp store in the country, which is basically THC. It's just about half potency of THC, but you can buy any dose.
But that's legal.
Perfectly legal. And apparently we have more and more data saying that Delta 8 is basically clinically identical to Delta 9, just not as potent.
Okay.
And the problem is, though, that in those hemp stores, nothing is controlled, nothing is tested, full of pollutants, no labeling, no child proof, a mess.
Right.
Don't buy it, people.
Okay.
What do they say? Don't do it at home.
No.
The what?
Just say no.
Just say no. Well, no, the bigger problem with Delta 8 is totally unevidenced, totally untested. Concern is that you can have some byproducts, you can have heavy metals in there, you can have all kinds of toxicity.
Well, I did a broadcast called Bottle of Lies, about all the false ingredients in, that come from China and other places that are used to make all the generic drugs we take. But also there's substitutions for Xanax and all kinds of other drugs so you're really not sure what you're getting when you even get a drug at a pharmacy. So Joan, I assume that you were not a heavy marijuana user before this book. I went
to NYU in the 60s, and enough said.
Has this book changed your view on the use of medical marijuana?
I worked for the Narcotic Addiction Control Commission, doing research in drug addiction, drug abuse, and marijuana was never an issue. I mean, we never, Misha and I had some discussions about this. It was never considered an addictive drug, never. It was only after that. What I never knew in all my research, I worked with a lot of drug addicts. I worked with mostly heroin addicts, methadone patients in my research, and I did some counseling. I never knew the medicinal value. Misha taught me all that. So I had no idea.
I still disagree with Joan that cannabis is not
addiction.
addictive. I disagree. I think
anyway.
it has addictive potential. Low, but it has.
Okay. But I really had no, my friends who were heavy pot users and stuff, nobody ever used it medicinally. And I think that one of the advantages of our book is that, hopefully even people who use marijuana to get high might learn something about medicinal value. And to get back to your point, Misha's point about how you don't know what's in it, we do have a very clear section on how to read labels. People don't know how to read labels. And that's we have some nice illustrations and the importance of labeling. And Misha's involved with an organization that's trying to do universal labeling, which would be a godsend. because there are medical groups. I forgot the name of it, Misha, but
TFCR,
yeah, we need
Doctors for Cannabis Regulation.
right. We need universal labeling so people know what they could get. So
I just want to reassure my audience, we're going to have you on again because I think we could talk for a long time. So someone asked, what are the THC-free CBD gummies effective for?
Right. So great question, because I like specifically question the gummies. The gummies are nothing. They're going to be not good for anything. I will give you one particular point how to take them. So if you swallow CBD, absorption is about 5%, maybe 10 if you're lucky. So basically, if there's a 5 milligrams in the gummy, which is common, it's 0.5 milligrams that you're actually getting, has no therapeutic potential for anything. So if you feel off, it's just placebo effect. There's no chance of this being effective for anything. So it's just a commercial gimmick of nothingness.
I mean, in the store,
Well, we have a famous expression in Russian. Sorry, it's got Russians. Not a good time to say this joke, but whatever.
Okay.
You know, there is a fence over there where wood is laying and there's bad word written on the fence. And doesn't mean that that's actually what's out there. There's just wood. So they're selling stuff that they just need to sell stuff. So it tastes good. And placebo effect is potent. Now, the way to get around to get some anti-anxiety and maybe a little bit of pain relief and maybe even some sleep help with, which is what I think CBD can do, you need to suck on them for a while. So most of the CBD gets absorbed a lot better in the mouth because it's a highly lipophilic molecule. So once it goes into the solution, or non-oily solution like water or gastric juices, absorption drops. So you really want to try to put it right on the skin or right on in the mouth, because you have fat molecules that will try to transfer the active ingredients right in. So that's the first thing. So kind of chew slowly, or better yet, kind of try to have a melt in the mouth. So that would be the first thing if you want to take that. And the dose will need to be high. I think for the CBD to have a good anxiolytic or sleep-inducing impact, you'd probably need to take 15, 20, 30, or even more. For sleep, I'd say 50 to 100. If you use it more for anxiety, like a public speaking, for example, then it'll probably be, somewhere between 15 to 30 minutes.
All right, so someone asked, about sleep, and they say, do I need a doctor to determine the amount? But a doctor can't legally determine the amount for you, I guess.
Well, so CBD is different, right? Well, so we actually probably should have mentioned that. So CBD, when we had when was the bill, 2017? Or the hemp agricultural bill? I always forget that. 15, Pharma bill. 18, right? Yeah. So the Farm Bill basically said, look, less than 0.3% THC is considered an agricultural product. So it actually does not get regulated by FDA as a supplement. It gets regulated under the Farm Bill, and that's puts it in a whole separate category, which is a blessing and a curse. Blessing because now it's a lot less regulated. You can just get it. The curse is the quality control, right? So there can be whatever. So that's an important distinction, because then doctors don't. There's no regulatory mechanism of any kind. It's just like supplement. People can just buy anything anywhere. I started getting totally overwhelmed when you fly into Baltimore airport, and the first thing you see when you walk out of the gate is the CBD store in an airport. Well, it's everywhere now, in every pharmacy, Whole Foods, and everywhere.
So I have a question for Joan. As a professional writer, as opposed to an unprofessional writer, what was it like to collaborate with a physician?
It was great. I mean, it was interesting. As I say, we had our clashes. I learned a lot medically. I think I taught Misha a lot sociologically, and writing. Doctors tend not to be the best writers and tend to use a lot of jargon. And my job is to be.
That's why I make a living.
Yeah, my job is to be a word doctor. And I was a word doctor to his medical doctoring, and trying to make things clear that whether the book also is not just written for consumers. We're hoping that the medical professionals, doctors, medical students, nurses, pharmacists will read this book, because doctors know diddly poo about medical marijuana. There've been endless studies, they just don't know anything about it. So the book had to be written in a way that was accessible to consumers, but not written at a low level that physicians and other medical professionals would get turned off. So I think that we really, Misha was happy to let me rewrite what he wrote. So I think, right, Misha?
Oh, I personally learned a lot from Joan, just because in reality, I'm, it's my English, my second language, and my writing is not very good. So I actually feel like I become a little better writer after this, just because I had to pay attention to your edits.
And Joan's husband is an editor who was my editor at American Health. So kind of small world.
Very small world.
I do want to get to this question.
Okay.
So someone said, I'm a quadriplegic, complete since 1984. Like my father, my blood pressure and heart rate ran very low before my injury. In the last few years, I've noticed that marijuana and CBD extract lower my blood pressure.
Correct.
Sometimes too much.
Correct. I just came back from the conference where this was first time studied. There's an actual 5 to 10% drop universally, particularly with THC. I don't think it's a CBD impact. It's mostly THC. There's no easy way around this. Good news is that effect is temporary. It only lasts for about an hour or two.
He says, when I have a episode and my blood pressure shoots up, the quickest way for me to reduce it is to smoke or vape. So I'm wondering, should this be used by other people with high blood pressure? But you say it's only a temporary effect.
Well, no, but you can take the edible forms, you can take other forms that will give it longer effect. So that's a great point. I mean, there's not enough data. This study, the Israeli study, I met with a person with the investigator, the principal investigator. I told him, look, we got to do this on a much larger scale in the US, because a lot of people are going to use it for other things. And if you have an anti-hypertensive effect, you may even be able to get off some of the medications that are used.
You're not suggesting people go off their hypertensive drugs?
No, I'm not. I mean, there's just the beginning of research, but this isn't exactly correct. And the funny part is that for years we've been hearing things like this, and historically doctors just poo-pooing all this patients' experiences, and now a lot of these things getting vindicated.
But I also thought that marijuana can speed your heart up too.
Correct.
Okay.
So there's tons of side effects.
Okay.
Dry mouth, dizziness, nausea, lethargy, or somnolence. But there's no serious side effects. All of the side effects, generally speaking, relatively mild. The only true fascinating serious side effects is what's called a hyperemesis syndrome. Was a cyclical vomiting, sometimes it's called. So you basically kind of enter into this periods where you vomit unstoppably for hours. And the only thing that seemingly helps is to smoke more pot or take hot showers for a long time, but then you vomit again. So it's sort of like it's a difficult disease to treat. We don't really see it a lot with medical. It's almost exclusively seen in recreational sphere where there is no CBD consumed. It's purely THC products. But, other than that, this is a very good question. And, the cannabis for paraplegia, especially for spasms and chronic pain that's associated with this, I have a number of my patients after the strokes for whom it's a godsend. As a geriatrician, we take care of a lot of people after strokes. Okay.
So is there a role for cannabis in the treatment of addiction to opioids?
It's probably one of the best questions today. So I'm going to answer it a little bit long because it requires a little long answer. First of all, in every state where cannabis was approved, there has been 30 to 50% decrease in an opioid use and in opioid related mortality. That alone, and by the way, you can say, well, that could be coincidental, sure. But with time, when they look at the data, the magnitude of effect increases. It starts at about 20% and increases up to 50. What's fascinating, it correlates directly with the number of doses prescribed. In a 2019 study that was published in JAMA, it's one of the top medical journals, somebody looked at the Medicare data. In states that approved cannabis, there was 4 million daily prescription decrease of opiates. Listen to this, everybody. 4 million prescriptions per day for the United States, in the states total that have approved medical cannabis. So that translated to tens of thousands saved life per year. So yes, absolutely, there is a role not just for addiction, but also for just generally getting away from opioids as a whole. And we can argue as to other methods of treatment, but why there is no discourse about this in the all kind of national level, I don't know. It's the most effective treatment strategy we have, by the way. We have nothing that comes even close to be 50% effective, but yet no one talks about it.
So
For the addiction, I would say, though, the CBD seems to be an interesting molecule because there's increasing data showing that CBD can decrease addictive behavior and addictive potential for not just the opioids, but for alcohol and other things.
So my question is, okay, one more. Is cannabis effective for the treatment of chronic headaches?
Yes, so there's two separate ways to answer this. So for migraines, the CBD in multiple studies has been shown to be effective, but general headaches that are non-CBD, especially tension headache, THC is very effective for a variety of different types. Well, generally any pain, including headache, I would say the cannabis should be first line in 2019, especially after the 2017 National Academies of Science report, where they basically said it's a type A, a grade A recommendation. We have no single medical treatment that has ever been deemed grade A for any chronic pain. The only grade A recommendation for chronic pain is cognitive behavioral therapy and physical therapy. There is no medical treatment that is considered grade A. NIS gave it grade A. But nothing happened after, by the way.
So Joan, giving your historical perspective, do you expect, I mean, I would have thought that under the Obama administration that marijuana would be moved from Schedule I, but it wasn't. I would expect under Biden, you know, and no one's talking about this. Why aren't they talking about it?
I mean, it's a political, it's a political issue. I mean, it's really, I think another problem is the pharmaceutical industry does not want marijuana to be legal. I mean, they're now, in the book, we talk about some of the chemicals, that the pharmaceutical companies actually have forms of marijuana that are given in hospitals and given to cancer patients that are extremely expensive, that have a lot of side effects.
$10,000 a month.
Yeah, that they're trying to sell and promote these cannabis drugs. There's one natural, one most are artificial. And they have a stake in keeping cannabis away. And I think it's the political pressure from the pharmaceutical industry. I mean, that's what happened.
So 4 million prescriptions per day. Do you guys understand what it translates to? When the average cost of opioid per month is about $150 to $200.
Right.
I mean, it's a staggering numbers. We're talking about we're talking about trillions of dollars over a few years. I mean, this is not cheap change.
But but in public health, we've had bans on cigarettes, and they've gotten very tough on cigarettes. They've gotten very, I mean, when there is the will to do it, I mean, you can't smoke anywhere really in New York City anymore, or in most cities in the United States. You can't smoke on airplanes, which you could, when we were growing up. You can't smoke on public transportation. And so there are ways to do these things. And I'm just surprised that there's no one to, I mean, is it even being discussed among politicians to move it, at least to do research?
I don't know. I mean, all I know is that the pharmaceutical industry wants to develop their own forms and have them approved by the FDA and not have natural marijuana, natural cannabis, and have it available. And actually, one thing Misha should talk about is that terpenes we have a lot in the book about terpenes.
Not enough.
Not enough. I know that,
No.
that natural products have terpenes.
So I think that's a big point. So there's something called entourage effect, where we always talk about THC and CBD, but in reality, you can't separate the efficacy of the sort of what we call a major and the major cannabinoids. We can't separate that from minor cannabinoids, which are all these other molecules, flavonoids and terpenes. Terpenes are the smell molecules. So, the pharma is going to try to isolate components, put them together and do something, which is fine. They should do it. But the reality is they're never going to be able to mimic the plant. And thank God. The reason for that is quite simple. There's about 200 plus constituencies. There's no way to figure it out. Let me give you one simple example. Right now, there was a study that was just recently done, and I was listening to this in Israel, where they took a couple of cancers, right? Probably everybody knows that if you take extract of cannabis, put them in a petri dish with cancer, all cancers die. There's not a single cancer that doesn't die. The question is which particular ingredients are effective, right? So that's what $1 million question that every lab is trying to. So they would do something like this. They'll take THC out, just leave CBD, take CBD out. So there are all these things that they do. And turns out there's like a whole bunch of particular molecules. Some of them don't even have names, which is this minor cannabinoids. Turns out that they're probably more important than THC and CBD. So we're just in the beginning of realizing all this, but the reality is to figure all that out, it's going to take a lot of time. And eventually, why bother, right? If you can have a whole plant, give it, and it's going to have the same impact, because that's what they do. They basically say, if I give the whole versus trying to isolate a few things, the end point, the result is the same. So this is where the botanical or the medical botanical products are going to probably be around and being as effective, as long as they don't do something crazy like prohibit it just for the sake of only having pharma, which I agree with Joan. This is where it's all going.
I think that's
where it's all going.
Really
that's what they want.
So what are, in other countries in the world, the FDA does not, the pharmaceutical company doesn't have the same lobbying power.
Correct.
So which countries in the world can a doctor prescribe marijuana to?
Israel, cannabis, Uruguay, bunch of European countries. So, and it's rapidly increasing. Costa Rica approved it just now, like a few weeks ago. The Peru is going to approve. The whole of the South America is going to, within 5 years, entire South America is going to approve it. I mean, maybe not every country, but most. And then some countries will take forever, like the former Soviet Union bloc. They're probably going to never approve it, or Arab countries, forget about it. There's a big taboo. So, but eventually, as we get more and more data, it's inevitable. The question is it going to happen towards medical cannabis, or is it going to happen toward FDA pharmaceutical?
But increasingly in the United States, more and more states are having.
I mean, let me put it this way.
Colorado has, they're making a lot of money. They're making.
Well, let me go back to money, because money talks. Cannabis has potential for almost every medical condition we have,
right? And
some form or the other. So if you're talking that the entire budget of the country is 10 trillion, 20% of it is medical budget. Right, so approximately 20% of that is a budget on pharmaceuticals. So what I'm telling you now, at least half of all the budget of pharmaceutical can be replaced with cannabis.
Okay.
Do you understand the volume? I mean, we're talking about industry that's going to dwarf entire alcohol. It's going to dwarf a whole bunch of large industries completely and utterly. Who doesn't want to get a cut on that, right? So that's the problem. The problem is the pharma knows all of this exactly, and they're trying to figure out how to get on the train or prohibit parts of the train and do some modifications here, of course. And it's an inevitable process. I don't think we can do much about it. It's just, how do we as a public going to advocate for our rights? And what are the politicians going to say?
So I've never been to a doctor who said, I think you should go out and get some CBD oil or things like that. Where would I find a doctor who would do that? In an integrative medical center?
No, actually, I think that's changing rapidly. I think that's just more and more. This is a matter of, like, you go back 30, 40 years ago and you say palliative medicine, nobody would know what you said. Now hospice is everywhere. So it's a matter of acceptance of a public opinion, and you know, more and more schools as they're going to teach. I mean, that's actually what I decided to do. My next kind of career move in this field, we're trying to create a national standard for education on this topic. It's a hard thing to do, but somebody has to do it. And so once you have kind of requirement that every student comes out of the medical schools knowing at least some of it, then you're going to not have this problem where you go to your doctor and they don't know what you're talking about. I mean, that's the case. That's why I wrote the book. That's what John said. You know, every medical student should read this, right? But
so I want to hold up the book. It's Medical Marijuana, Dr. Kogan's Evidence-Based Guide to the Health Benefits of Cannabis and CBD. I know you can get it on Amazon. You can get it at local bookstores. It's a very interesting read, very well written.
it's very entertaining.
Also,
It's reflective. It's reflective of our personalities, right?
And it also tells you how to, besides the treatment for medical disease, it also tells you about, how to find a good dispensary. So there's some very practical things in it. See, I did read the book, right? So,
yes. And also how to save money, cost saving. We have
yeah, that's one thing we didn't even talk about, because unfortunately a lot of it's all out of pocket. You cannot get it insurance covered, and it can be quite expensive.
In Colorado, they explained to me that that recreational marijuana is taxed twice or 3 times the amount that medical marijuana is. So no doctor can tell you don't have back pain. So a lot of people have that card that lets you get the medical marijuana, even though they're using it recreationally. Anyway, I want to thank my guests, Mikhail Kogan and Joan Liebmann-Smith, who I've known a long time. You're also a SWINY member. I forgot to mention that.
Yes, I am.
That's good. So
great organization.
Thank you very much.
Wonderful talks.
Thank you. And we're going to announce our next couple of talks next week. And I want to thank Joe Bonner, my co-chair and great friend, for helping out and putting this together. And thank you. And Misha, we hope you heal quickly.
Okay. I already feel better talking to you guys. So.
Thank you. All right.
Thank you for inviting us.
Thank you so much. It's great.
And I hope you'll come back, and I think I'd like to discuss, go into more detail about, how a treat helps the different illnesses. So.
And and also the science here evolves so quickly. I think it's like I didn't even talk about the fact that right now we're doing a small study showing that CBDA, which is an acidic form of CBD, seems to cut the COVID risk by about 70%. So, there's things like this going to evolve here, left and right, and this is a kind of a topic that, just like neuroscience, it's like every time you talk about, there's something new, right?
It's a pity you didn't take it, right? So. Okay. Anyway, take care, and everyone out there, stay safe.
Stay safe.
Thank you. Thank you for having us.
You're welcome. Bye-bye.
Bye.